Hello and good evening. Thank you for joining us tonight. Uh, we're going to be discussing advanced prostate cancer and your treatment options. I'm Dr. Joshua Palka, one of the partners here at Michigan Institute of Urology. I did my medical training here in the great state of Michigan. I also did my residency in urology down at the Detroit Medical Center. And then I took an elective fellowship over in St. Louis at the Washington University of St. Louis, where I specialized in urologic cancers and minimally invasive surgery. My specialty that I focus on is urologic oncology. However, I do have a vast practice of other um, uh, areas, including kidney stones and erectile dysfunction. And I'm mainly located on the west side, including West Bloomfield, Brighton, and Livonia. So let's jump right into it tonight. So the topics that we're going to cover, what is exactly advanced prostate cancer? What is that defined as? Certain common terms that we're going to be discussing tonight, just so we have a basis of an understanding of what we're going to be discussing. We'll also be touching on how does prostate cancer progress? Additionally, what is each stage of this progression and treatment options that are available for each stage? We'll touch a little bit on genetic testing, the two different subtypes of genetic testing. And then finally, we'll also discuss the clinical trials that we have here at the Michigan Institute of Urology. We also have some other resources that we're going to highlight and leave hyperlinks that you can access on your computer tonight for patient navigators and different support groups that we partner with here in the area. All right, so what exactly is the prostate? It is a common question that I get a lot in the office, and really what it is that it's a gland that is located below the bladder. It actually encompasses over top the urethra, such that the urethra passes right through it, and it sits right in front of the rectum. Now, the issue with the prostate is that there is an abundant nerve supply that surrounds it, and namely, those are the nerves that give life to the penis and allows it to have an erection. And so when we talk treatment later on in the presentation, that's one of the side effects that we want to counsel you as a patient that can occur, including erectile dysfunction. And so when we offer treatment, we don't offer it lightly because we know that there are side effects that can occur. What the prostate's job, it truly is fundamental for producing fluid that helps liquefy semen and allow it to stay in its liquid form so that it doesn't congeal or thicken within the body. Now, the size of the prostate, this is another great area of conversation in the sense that the prostate size does not necessarily correlate with risk of prostate cancer. Additionally, prostate size does grow over time, namely that in younger men, prostates are approximately the size of a walnut. And as we age, it gets larger. Whether there's cancer there or not, that this is a cross that we must bear as men. And that gets into the whole realm of benign prostatic hyperplasia. And that's a topic we can discuss at another time. So what is prostate cancer? Essentially. So cancer, the definition is, normal cells that are growing out of control. It's unregulated growth of this type of cell. The most common subtype, about 95% of prostate cancer, is comprised of what's considered adenocarcinoma, which is a type of cancer that originates in glandular tissue. So when we discuss on your biopsy report the Gleason score, this is another interesting topic in that the Gleason score is essentially the level of which the glands are looking dysfunctional. And so when we give you a report such as 3 + 4 = 7, that is not the same as a patient who has a Gleason score of 4 + 3 = 7, in the sense that the first number that is presented is the most common subtype that the pathologist sees of atypical cells and glands in the biopsy specimen. And so the first number being a 3 is much better than a first number being a 4. Now, as we talk further about advanced prostate cancer, most of the time, these high-risk type of prostate cancers are much higher Gleason scores than that, namely Gleason's 4 and 5. And so we'll talk more about that later on in terms of treatment options that we can offer you. Now, metastasis is a general term used for all types of cancers, including prostate cancer, that defines it as cancer cells that have traveled to other parts of the body that it did not originate in that initial gland. And so for prostate cancer, metastasis is defined as anything outside of the prostate, whether that is what we call nodal metastasis, meaning it has gone to the pelvic lymph nodes, or if we start talking about metastasis outside of the pelvis, we'll kind of define which sort of treatment options and evaluation we need to consider moving forward. Now, prostate cancer statistics. By and large, Black men are at a higher risk of not only developing prostate cancer, but also developing advanced prostate cancer on the initial diagnosis. As you can see here in the slide, 1 in 8 white men will be diagnosed with prostate cancer in their lifetime, while 1 in 6 Black men will be diagnosed with prostate cancer in their lifetime, which has led to several recommendations in different governing bodies that certain subgroups of patients should be considered for earlier testing for prostate cancer. Now, up to 40% of men will be diagnosed with a high-risk type of prostate cancer at the initial outset of their journey. Some of these men will even have metastatic disease at the time of their diagnosis. That range, depending on the study you look at, goes anywhere between 5 and 15%. Now, unfortunately, due to historical outcomes of different bodies recommending PSA screening, we have seen this level of metastatic disease actually rise for the first time in the United States. And so it's important that we still consider prostate cancer screening as a tool to prevent these sort of discoveries and diagnoses in men. Now, those with metastatic disease or high-risk localized disease may benefit from treatment intensification at the outset of their diagnosis. And that leads us into another conversation that we're going to have later on in the presentation regarding the different treatment options that are available. So again, common terms, you'll see abbreviated, as you have seen already. PC is prostate cancer. APC is advanced prostate cancer. ADT is another phrase that'll be thrown around a lot, and that is androgen deprivation therapy. What this is we use typically medications, but also sometimes surgery to reduce testosterone levels in the body so that we can essentially eliminate the food source of prostate cancer, which is testosterone, and reduce the risk of spread or worsening of the disease. This was actually a discovery back in the early 40s. It was the first urologist to win the Nobel Prize that they discovered men who had been accidentally castrated during World War II had less levels of prostate cancer amongst that cohort compared to those who had not. And so it was the spark that led to multiple other treatment options that were made available for men with prostate cancer. Now, that leads into our newest iteration of treatment options, which are NHTs, or novel hormone therapy. This includes enzalutamide or Xtandi, apalutamide or Aleta, and darolutamide or Nubeqa. There's some other medications that are listed at the bottom, abiraterone. This one works in a different pathway, but they all essentially are designed to either eliminate the production of testosterone or block the binding of testosterone to androgen receptors. Now, castration is defined as testosterone levels that have been reduced by either surgery or medications, like we spoke about, to a level of less than 50. Ideally, we try to reduce it to a level of less than 20 to 25. And then navigators, these are specifically trained MIU staff and other staff who are utilized to help remove any sort of barriers and ensure that the patient, you, are receiving the treatment that you need and deserve. So how does advanced prostate cancer progress? Now, take this in the sense that not all patients will progress from localized to recurrence to metastatic and then castrate resistant and hormone sensitive. It's a continuum. Some patients will stop at localized and that's all they'll go to. Some patients will be diagnosed at metastatic, castrate sensitive at the outset, or hormone sensitive is another way to phrase that. And so there's a lot of interplay between these different levels of prostate cancer that don't necessarily one lead to another. Now, localized prostate cancer, this is the most common form of prostate cancer that we diagnose. What this is defined as is that the cancer has not spread beyond the prostate or has not reoccurred after the initial treatment that has been given. This is diagnosed typically with PSA blood test to screen for prostate cancer. Those that have gone on then to a prostate biopsy, whether that is utilizing an MRI fusion biopsy or a standard biopsy in the office, is up to the discretion of the patient and the physician in partnership with each other. Some patients who have been diagnosed with more advanced or more risky prostate cancer may require advanced imaging. What this includes in the past was a bone scan and a CT scan, but this has now evolved into a PSMA PET scan, which is specifically designed for prostate cancer. Treatment options for localized prostate cancer include, but are not limited to, surgery, which is a prostatectomy typically performed laparoscopically with the Da Vinci robot, and radiation therapy. Now, radiation therapy has multiple flavors that it comes in, and it's best to discuss with a radiation oncologist as to which therapy within subset therapy within radiation would best suit you as the patient. There are some other ablative options that are being investigated currently. Those are including high intensity focal ablation with using ultrasound or HIFU. Cryotherapy is another ablative therapy, and then NanoKnife, which is an electro therapy, all being investigated currently by the NCCN to essentially assess their efficacy in localized prostate cancer. Now, biochemical recurrence, this is defined differently between a patient who has had radiation and a patient who has had surgery. In a patient who has had surgery, there should be no detectable PSA available after the prostatectomy and sometimes lymph node dissection has been performed. Therefore, if the PSA has risen to above either 0.1 in a high-risk patient, meaning a elevated Gleason score or high-risk features such as extra prostatic extension, meaning the prostate cancer was starting to extend outside of the gland just microscopically, or a positive margin, the cutoff for recurrence in that situation would be 0.1. Whereas if the high-risk features are not present, the cutoff is 0.2. Now, with radiation, it's a little bit more nuanced in the sense that you still have a prostate, and therefore prostate tissue will still create PSA. What we define recurrence in a radiated patient is a level of 2 greater than the nadir. Now, nadir, that's a phrase we use and throw around, but what it essentially boils down to is the lowest level that your PSA has gone to and stays at for at least typically 3 consecutive lab draws. If it rises to above 2 or 2 above that level would be considered biochemical recurrence. Now, the way we diagnose that is not only with lab work, but then we go on to do imaging in patients who have had a prostatectomy and radiated patients. And then patients who have had radiation and their imaging comes back negative, we try to do also another prostate biopsy to identify 2 things. 1, is it truly localized to the prostate? And 2, has the cancer increased in its Gleason scoring and aggressiveness? Treatment options, again, are as follows. You can do a radical prostatectomy for a patient who's had radiation therapy. However, it is a bit of a challenge, and there are some complications that can occur in that situation. Cryotherapy is a great option as an ablative therapy for patients who have recurred. Radiation therapy with or without androgen deprivation therapy, and then possibly the utilization of a novel hormone therapy or other therapies in addition to radiation have also been shown to be beneficial. Now, let's start talking about metastatic disease. Now, this subset of patients, the non-metastatic castrate-resistant prostate cancer, is a bit of a nuanced type of prostate cancer. Commonly, this is found in patients who have undergone treatment. They have a level of PSA that is rising. Treatment has been initiated, and the PSA continues to rise. However, on imaging, there is no identified prostate cancer, either on a bone scan, CT scan, or PSMA PET scan. Typically, these patients will either undergo closer surveillance with PSA blood draws and imaging at timed intervals to assess whether or not they have then become metastatic. Or in some patients, we elect to increase the level of medication and the intensity of medication so that we can reduce the PSA level back to a non-identifiable level again. And so this subset, while rare, does occur, but we're not going to spend a lot of time on it due to the fact of its rarity. Now, let's start talking about metastatic castrate-sensitive prostate cancer. This is the most common subtype of prostate cancer that is found on initial diagnosis of the metastatic subtype. The way we diagnose it, again, is via imaging. A lot of the times patients will come in with other complaints such as pain in their hips, their spine, their back, and a PSA blood draw is performed and it is elevated. And on the imaging for the pain, we find lesions that look concerning for cancer. And then it is confirmed then with either a bone biopsy or a PSMA PET scan. Previously, as of about 3 or 4 years ago, we would initiate just purely androgen deprivation therapy. In recent times, multiple studies have found that intensifying the treatment on the outset of the diagnosis has led to not only overall survival benefits, but also it has led to increased reduction in events such as fractures from prostate cancer, and then also overall has reduced progression-free survival, meaning on imaging, the cancer does not progress nearly as often. Ideally, if the patient is a candidate, we try to identify if they can handle what was called triplet therapy. What that includes is an androgen deprivation therapy, whether that be with a shot of Eligard or Lupron or Firmagon, or a newer oral medication known as Orgovyx, a non-hormonal therapy such as enzalutamide, apalutamide, or darolutamide, or abiraterone, in addition to then a chemotherapeutic agent known as docetaxel. Now, the chemotherapeutic regimen that we typically institute is in partnership with a medical oncologist. And so they will be typically the one that would identify whether or not the patient is a candidate for this therapy. If the patient is not a candidate for chemotherapy, which sometimes occurs, dual therapy or doublet therapy with removal of docetaxel has also been found to be improving patients' overall survival and, again, progression-free survival, such that the cancer does not progress on imaging or with PSA blood draws. In certain patients who have what we consider a phrase called oligometastatic disease, oligo meaning a solitary lesion in either the bone, on, say, like a rib or in the hip, we are finding that utilization of a type of radiation called SBRT has been very beneficial as well, to reduce cancer progression and improve overall survival. And as always, we try to identify patients who may benefit from a clinical trial such that they're able to receive not only standard of care, but also the most cutting edge therapy that medicine currently has to offer. We then progressed to castrate-resistant metastatic prostate cancer. Now, what this is metastatic disease that is no longer, unfortunately, responding to the previous therapy that we had discussed, and that includes doublet therapy and triplet therapy and other forms of therapy that we can offer. In this situation, we identify these patients by a rising PSA and a testosterone level that has been shown to be castrate, meaning less than 50, ideally less than 20. In this subset of patients, there has been an explosion of new research and new developments of treatment options that it's honestly challenging to keep up with, because we come out with a new one practically every month or every couple months. What these treatment options include are the similar dual therapy and triplet therapy, but also now includes therapies such as radioligand therapy. And to put it in a better way, using the PSMA PET scan to identify patients who have PSMA PET lesions, that the cancer treatment binds to those lesions and treats it at the source of where the cancer is. Additionally, using therapies such as immunotherapy, which is Provenge or Sipuleucel T. This is a good option for patients who have minimal symptoms, minimal disease burden, and are able to utilize their own body's immune system to attack the cancer in a fashion that has less side effects than the other medications. Additionally, we're finding pembrolizumab, also known as Keytruda, does have a role in prostate cancer as well. Now, these are patients in a small subset of patients who have what are called microsatellite instability levels that are above a certain threshold. Those have also been shown to have some benefit from this medication as well. PARP inhibitors are another option. These are typically given to patients who have genetic anomalies, whether it be a germline mutation or a somatic mutation. We'll talk more in detail about what that means. But multiple different PARP inhibitors have been identified, whether on their own or in conjunction with abiraterone or enzalutamide, to help patients have another option that previously didn't have any options for these types of cancers. And then again, clinical trials. We have multiple clinical trials for patients that have gone on to castrate-resistant prostate cancer. What I'd like to do is, in this next slide, just a little background of a little video to kind of discuss a little bit further what Pluvicto or lutetium, these radioligand medications can do for you.
There is an urgent need for clinically relevant and targetable biomarkers that can help guide treatment selection in patients with progressing mCRPC. PSMA is a biomarker that is expressed in more than 80% of men with prostate cancer, making it an ideal diagnostic and therapeutic target. PSMA, a transmembrane protein expressed on prostate cancer cells, can be visualized using PSMA PET. Knowing your patient with mCRPC is PSMA positive may enable you to offer a PSMA-targeted radioligand therapy, or RLT. For a PSMA PET scan, a patient first receives an injection of a PSMA-targeted radiotracer that binds to PSMA on the cell surface of PSMA-expressing tumor cells. The patient then undergoes a PSMA PET scan to identify the location of the PSMA-positive tumor cells wherever they are in the body, including bone, nodal, and visceral metastases. Once a patient is confirmed to have PSMA-positive mCRPC, he may be eligible for treatment with Pluvicto, the first and only PSMA-targeted radioligand therapy for patients with PSMA-positive mCRPC who have been treated with an androgen receptor pathway inhibitor. Pluvicto is comprised of two key components, lutetium-177, a cytotoxic radionuclide, and PSMA-617, a PSMA-targeting ligand. Pluvicto is a PSMA-targeted radioligand therapy that targets PSMA-positive cells, including prostate cancer cells, that were identified through the PSMA PET scan. Pluvicto targets and binds to cell surface PSMA receptors that are expressed in prostate cancer, including bone, nodal, and visceral metastases. After binding to PSMA, Pluvicto undergoes endocytosis and is internalized into the cell. After dissociation of Pluvicto from the PSMA receptor, the receptor is recycled to the cell surface. Lutetium-177, the cytotoxic radionuclide of Pluvicto, emits DNA-breaking radiation within the cell. The short-range path length of radiation emitted by Pluvicto, approximately 2 millimeters maximum, induces single and double-stranded DNA breaks in target cells as well as surrounding cells, which can lead to cell death. Scan to determine PSMA status. If you see PSMA, target it with Pluvicto.
So as you can see, there's a huge role with different therapies that we can offer based on different ways to attack the cancer cell. Now, there's another option, which is immunotherapy, and we're going to see that here, utilizing Sipuleucel-T or Provenge. It's a little older medication, but it works in an interesting fashion as well. So we got another quick video here that we can show you.
Prostate cancer can evade or inhibit the body's natural immune process, allowing cancer cells to grow and spread unchecked. Provenge immunotherapy works differently from other advanced prostate cancer treatment options by generating a robust immune response, causing trained proliferating T cells to target and attack prostate cancer cells. Beginning with leukapheresis, the patient's own immune cells, along with some platelets and red blood cells, are collected for use in their personalized immunotherapy. These cells are then cultured with a recombinant antigen, PAP-GS-CSF. Prostatic acid phosphatase, PAP, is an antigen expressed on more than 95% of prostate cancer cells. GM-CSF is a cytokine that activates the immune system. Together, these fused proteins specifically train and activate the collected antigen-presenting cells, or APCs. As the patient's APCs process PAP-GM-CSF, they begin to present pieces of the antigen on their surface. Upon infusion, Provenge activates the patient's own resting T cells, which proliferate. These activated T cells are able to recognize, target, and attack PAP antigen-expressing prostate cancer cells, resulting in a specific and lasting immune response. Be more proactive with Provenge to help extend survival.
All right. So as you can see, the multiple different ways in which we can attack the prostate cancer cells, with lots of new research and clinical trials looking at other options, including HRR mutations. Those are the PARP inhibitors, which would include Lynparza, Talzenna. These are great medications that are becoming more readily available as they become better studied, so that we know exactly what it is that we're dealing with, and being able to offer patients other options that previously we never really had any options available for. And that leads us into our next topic of discussion, which is genetic testing. This is something that many, if not all of you, whether you as the patient or your family member, should be discussing with your physician. And they should be discussing with you on the outset of diagnosis, if there is any risk features of high risk features or metastatic disease, it is imperative that we do testing, whether it be germline testing or somatic testing of the tumor cells, to identify whether or not there are any genetic mutations that may, one, benefit for therapy, and two, benefit in terms of prediction for other members of the family. Now, with germline testing, what this is essentially is the DNA that was given to you by your mom and dad. It's a blood test, typically just drawn right in the office, and utilizing what we call a PCR, we identify any of approximately 30 to 50 mutations that may have an effect with prostate cancer. Now, what you'll see more and more coming out in the news and other medical journals is that the BRCA mutation that you commonly have heard with breast cancer in women has actually been found to also be associated with high-risk features in prostate cancer, and that's namely the BRCA2 gene. So even patients who are men, the BRCA2 gene has huge implications with regards to opportunities for treatment, and then also opportunities for prognosis and identifying patients within your family or family members that may need to be screened at an earlier level. Now, somatic testing is a way in which we test the genetic level of the tumor itself, whether it be from a biopsy, from a prostate specimen, or from a bone biopsy. Sometimes we can even do what's called a liquid biopsy, which is just, again, blood sampling in the office. And what's interesting about somatic testing is that is not static, meaning that if, God forbid, the cancer were to progress, it's another opportunity to do further testing to see if there has been a new genetic anomaly that has occurred and a new opportunity for treatment and therapy for the patient. And so you'll hear many of us in the office talk to you about different testing, and that's really what we're talking about here. Now, these are the clinical trials at the Michigan Institute of Urology. We're very proud to partner with several different research groups, whether that be through the NIH, through industry, or through other groups within the United States that allow us to provide these opportunities for patients to not only have standard of care, but also have an opportunity to obtain therapies that possibly wouldn't be available to other patients in any other settings. The Legion 100 study is a very exciting study for patients who are castrate resistant and metastatic that utilizes, again, in a similar fashion to the PSMA lutetium treatment, utilizing the body's own ability to essentially attack the cancer cells without needing the use of agents like chemotherapy that could be, toxic to the body. Again, utilizing Provenge in the Prov-1 study, identifying patients who may benefit for this is also a very exciting new endeavor. And then the EVO-PAR study that we're utilizing a different type of medication in conjunction with the standard of care to see if we can identify whether or not there's any benefit to this. And so if you are suffering or your family member is suffering from advanced prostate cancer, always ask your urologist, your medical oncologist, is there any opportunities for clinical trials to be enrolled into? Now, we do also have patient navigators here at Michigan Institute of Urology. These navigators are here to help you as the patient. Prostate cancer in and of itself is a very daunting and confusing type of cancer. And when you add the layer of complexity of metastatic disease, different buckets of metastatic disease, and different ways in which we have to treat, identify, image, it can become overwhelming at times. And so we try to make the journey easier by helping you understand the diagnosis, coordinating the communication between you as the physician, or us as the physician, and you as the patient or the patient's family member. And then also trying to facilitate any sort of scheduling of treatments. And then also trying to evaluate not only your response to the therapy from a scientific standpoint, but also mentally. A lot of these medications can have side effects that, cause fatigue, weakness, and we want to treat you as a whole person. We don't want to treat you as a patient with prostate cancer. We want to treat you as Josh with, metastatic disease that just so happens to have cancer, and seeing you as a whole person, really. If you have any questions or concerns or want to learn more, the phone number is listed below, and the email is also listed there. And I believe there'll also be hyperlinks sent out to you after this presentation. Additionally, as I was mentioning earlier, we want to see all of our patients and family members as well as a whole person. And what that includes, again, is the mental struggle that comes along with not only a cancer diagnosis, but a prostate cancer diagnosis. A lot of intimate things can happen after treatment. And I can talk to you all day long as a physician, but I don't know what it's like to go through this. And that's where we try to provide these cancer support groups so that you as the patient or the family member can get together with other like-minded individuals and bounce ideas off each other, keep in touch with each other and try to really support each other in the sense that, you might be going through this at this time. What are things to anticipate in the future? And so again, this group meets every second Wednesday of each month at 6 p.m. at our town center location over in Troy off Big Beaver. And again, the hyperlink is located down below, and I believe it'll be emailed out to you afterward. Additionally, there are typically signs at each of our locations that if you want more information, just ask one of the front desk members or your physician. It's been a pleasure being able to discuss this with you all this evening. I will open it up for questions now. Additionally, if you have further questions that are personal, feel free to make an appointment with either me or another physician in the group that may be closer to your home, so that way we can offer you the personalized care. All right, so let's go through the questions here. So the first question here, is there a relationship between PSA and testosterone? And then there's a second question, is a high level of testosterone an indication of a high PSA and an indication of advanced prostate cancer? So that's a great question. The relationship between PSA and testosterone differs in the sense that with a diagnosis of prostate cancer, the testosterone level, especially if it's advanced prostate cancer, the testosterone level must be below 50 to 20, ideally 20. There's no relationship necessarily between the two blood levels of a PSA and a testosterone level. It's namely the PSA is a representation of your prostate cancer more than anything. And so if you've already undergone treatment and the PSA level, say, is undetectable, your testosterone level can be as high as you want because essentially there's no cancer there anymore to be concerned about. Now, on the flip side of that, if the PSA level is rising after treatment and you have a normal to high level of testosterone and you're undergoing therapy, that may be a sign that either the therapy is not being effective because it is not currently castrating you to the level below 50, and there may need to be a reevaluation of your therapy at that time. And then a high level of testosterone does not necessarily indicate a high PSA or vice versa. However, a high level of PSA in and of itself, namely a PSA of greater than 50, is concerning for high-risk disease in a patient with undiagnosed prostate cancer. Now, again, PSA in and of itself is not a diagnostic criteria for prostate cancer. Therefore, it's important to go through an evaluation. Multiple things can raise a PSA, namely to a level of that high as like an infection. Even something as simple as having sex the night before can rise the PSA. And so it's important to see your physician to make sure that we do a thorough evaluation, including possibly a biopsy, to identify whether or not it truly is prostate cancer. The next question is, what is the life expectancy after a patient reaches metastatic castrate-sensitive prostate cancer? So this number varies and is actually improving over the last several years. If you look at the studies done, the longitudinal studies done between the early to late 2000s, that number ranges anywhere from 5 to 10 years. Fortunately, with newer therapies, that number is increasing. The median level is increasing. Now, when the patient reaches a castrate resistance level, the next question is, what is the life expectancy at that stage? Again, it's a hard question to answer because of the newer forms of therapy that we have. That number can range anywhere from less than a year, unfortunately, but as high as several years. And so it really comes down to a personalized, response as to what sort of other implications are there regarding, genetic mutations, PSMA response, and in response to other therapies as well. All excellent questions, though. And so if that's it, again, thank you so much for your time. Thank you for being with me this afternoon and evening. And again, if you have any further questions, there should be a little area on the bottom corner of the webinar that if you want to make an appointment, feel free to click that, or reach out to any of our locations that may be near your home, and we'll get you an appointment as soon as possible. Thank you very much, and have a great evening.